I've tried to de-roof once. But what I realized, it was too small, and not enough for my cannula to go through to give the viscoelastic injection. So I decided to go again and do another perforation. So and what happens, I'm getting a small aqueous flow outside. So I perforated. I was dejected because that's what I wanted to do for him. And so anyway, I thought, let me try to retrieve it. I tried to inject a viscoelastic, but half the viscoelastic went into the anterior chamber. There's a very small portion of the bubble remnant here. So I decided to go ahead with a manual dissection. And with manual dissection, what I was doing was, I was trying to get into the area of the bubble where some amount of the bubble is still, the air is still retained. But as he was doing it, the AC was collapsing constantly, and I know that it's going to produce a problem, the endothelium. So I put a suture in the area which had a pretty large, as you can see, pretty large area of perf. And once I put the suture, then I felt that I was able to isolate the bubble here much better. So once I did that, I decided to again de-roof the bubble. And this time, very gently, just once, I'm just doing it as a slow motion. And you can see that the bubble, a little bit of the air has escaped. And now I'm injecting the viscoelastic, and the full bubble is reformed. And from then on, then it becomes very easy. Once you get a big bubble, then you can just do the 4-quadrant technique and expose the decimates to the maximum possible extent. And in this particular case, again, I have a peripheral limb of stromal tissue which needs to be dissected. And this case clearly took me about an hour because I had to do a manual dissection as well, very slowly. And I just made sure so that I can suture this case properly and give him a good quality of vision, because otherwise patient might have high astigmatism. Now I'm snipping off the area which I have sutured and re-injecting the bubble. And now I'm getting a nice smooth bubble. There's no perforation, is well sealed. And normally when there is a perforation, it's better to use the same size graft. Then the chance of double anterior chamber is much less. But you always have to watch out for it. And in this situation, unfortunately, we cannot do a PI. So sometimes you can't do a full air, you can't compress the anterior chamber with air like we would do in a DSEK patient, where you can actually fill it up there because you have an inferior PI. And you can see that the postoperatively, there's a site of perforation, had sealed very well, and eventually he did extremely well. So this is a pre and post-op picture. So the other postoperative complications that we see are the double anterior chamber, particularly in patients with mismatched grafts, even without a perforation, and also in patients who have had a large perforation. Then decimus membrane folds are more common in patients with keratoconus because you have a very large area, surface area, and you try to compress the cone, then they tend to have folds. If there's a fold in the center, you have to reapply the graft. Otherwise, if it's in the periphery, just leave it alone. Delayed epithelialization is again a problem in mismatched grafts, such as in keratoconus, as well as in patients who have very thin corneas in the periphery. Stromal melt because of persistent epithelial defect, and all these things leading on to the infection and epithelial ingrowth. So interface haze, anywhere there's an interface, there can be an interface haze, there can be interface infiltrates, there can be interface vascularization, so watch out for it. Recurrence of host pathology, particularly in dystrophies, is very common. High astigmatism is again a bugbear, and of course the suboptimal visual acuity. So this is a patient who had a double anterior chamber. If the double AC is very small, you can just observe over a period of time the fluid tends to get evaporate, tends to stick together. But in very large ones, you definitely need to inject air. And in case of recurrent separation, I would like to go in for a non-expansile C3F8 or SF6 gas to retain the bubble for a longer time. And in case of persistent double AC, change the graft to a smaller size and use venting incisions that you would do for a DSEK. So this is a patient with a delayed epithelial healing, also underwent DALK for a large keratoconus, and I had to put her on autologous serum finally before she healed. And this is a patient again who had a pellucid marginal degeneration, had a very large graft, and developed an infection again, had to do a smaller graft, as you can see, and again the persistent epithelial defect started. So I had to give him Botox, and then afterwards I did a lateral trachygraphy. So major problems in LK could be because of graft-host junction mismatch. So in these cases, use a BCL or a Benton's lubrication. You can use punctal plugs, autologous serum, and ultimately tarsotaphy. So DM folds that I've already explained to you, central striate need not be managed. High astigmatism is a bugbear, and selective suture removal can be done as you would do in a PK. This patient had a 15.44 and came down to 7, and over a period of time she improved very well. So though most of the times you would like to have the results such as what we see in the left side of the picture, but most often we do have problems, and it's very important to anticipate the problems, particularly in patients who have a high risk, and explain the risk to the patient, as well as have enough patience to go through this. DALK has a long learning curve, so attending wet labs helps in reducing the on-table complications. Practice on donor eyes. Near total DALK should be kept as an option, particularly in young patients, and small perforations can be managed without converting to PK. Thank you.
Great. Thank you so much, Sujatha. Before, Somasheila sets it up, doing a PI and leaving a full AFL, would that be an option for patients who've had intra-op perforations? Because I think that would be the most common DALK complication surgically. So whether you would actually leave a full AFL, do an inferior PI, and so that there is no chance of a double AC.
Yeah, we may have to do it from the outside. You know, you have to make a small incision. I've never done it, because what I do is I place a same size graft. Never had any problems. If you have a larger size, a 0.25, 0.5 oversized graft, then we'll end up in trouble. And I've had a patient who had 3 times who had a double AC, and so I put her on C3F8, and then it settled. I've never done a PI. Yes, you're right, but I've never done it.
Okay. Thank you, Sujatha.